Thank you very much, Georgie. You are truly an inspiration. It's been a pleasure to work with you, and it's a pleasure to be back in England. I lived in London as a boy for several years, regrettably not long enough to correct my accent, but we can't have everything. But it always feels like home when I come back here, so it's really wonderful. Today I'm going to talk about the patients that I saw over a period of 30 years, over 7,000 patients, and what they had in common was that their diagnostic tests did not explain their illness. And as you'll hear, it's not just about pain. As was mentioned this morning, patients with psychophysiologic disorders or stress illness can have a variety of different symptoms. We'll start with a patient who meant a lot to me in the course of my career, because I saw her fairly early on when I was still trying to figure out if I was doing some good or if I was likely to be dangerous. And this patient was hospitalized for an attack of nausea, vomiting, and extreme dizziness. And the attack went on for several days, but eventually she recovered fully. And she was hospitalized not in my institution, but at another and very prestigious hospital on the West Coast. And she continued to have these attacks every couple of months. And they asked a variety, actually up to a dozen different specialists, consultants to see her, and none of them could come up with anything. In the third year of her illness, a psychiatrist was asked to see her, but unfortunately, as was too often the case, a psychiatrist didn't know what to look for, completely missed the diagnosis. Too bad Dr. Zafarides was not available. But he sent her back to her primary care clinician without any answers, where she continued to have attacks for the next 13 years. Had a total of 60 admissions to this hospital. Eventually happened to have an attack in my city, was admitted to my hospital. I went to see her, and she said, "Doctor, don't waste your time. I've already had every diagnostic test, and I'm going to get better in a couple of days anyway, so you'd be better off seeing your other patients." Well, I couldn't resist a challenge like that. And to make a long story short, after a 1-hour conversation, not only did we have a confirmed diagnosis, but we had an effective treatment, and she never had another attack. And we'll talk a little bit later about exactly how she was diagnosed. It was fairly straightforward, but first I want to go through the process that I use for uncovering the cause of illness in patients like this. And first of all, the name, the term that my colleagues and I in the U.S. have centered on is psychophysiologic disorder. We had a long discussion about this via email a couple of years ago. The term that's gaining currency in the EU is bodily distress syndrome. And of course, here in the UK, stress illness is quite commonly used. But you can see the definition there. It's an enormously common condition. It's estimated approximately 1 adult in 6 suffers from this. So we're talking about 8 million people in the UK. 30% of outpatient primary care visits are down to this condition. Fortunately, many of these people improve on their own. There is a spectrum of severity. The far end of the spectrum of severity would probably be people in Frances Summer Anderson's experience, and she's going to talk to you later this afternoon. But some of them are, can be cured in a 1-hour conversation. Other people are going to need years of psychotherapy to make similar progress. As was mentioned this morning, the range of symptoms is literally from head to toe. Headaches, ringing in the ears, temporomandibular joint problems, visual disturbances, pseudo-seizures where the individual appears to be fitting, but when you put the EEG leads on, no seizure activity is identified. A lump in the throat, difficulty swallowing, fibromyalgia, irritable bowel syndrome, difficulty breathing, chronic cough, chest pains, low back pain, cervical spine pain, abdominal pain, pelvic pain, interstitial cystitis, numbness and tingling in the extremities, itching of the skin, bizarre symptoms that seem to make no sense, no physiologic sense. One of my patients had itching of his skin that migrated from place to place in his body from day to day. So one day he might itch here, the next day between his shoulder blades, the next day both his hands would itch. So very, very odd symptoms that were proven to be due to psychophysiologic disorders. The only common denominator in this population is that they tend to have more than one symptom at a time. They don't necessarily have to, but oftentimes they do. And if a patient has 6 or more symptoms, there's a 90% chance that they've got a PPD behind it. My personal record patient had 27 different symptoms, all of which were relieved in about 4 or 5 weeks. The duration of symptoms can also be quite variable. My average patient was ill for 3.5 years, but one of my patients was ill for 79 years. And I have a story later on, if we have time, of a patient who was ill for 55 years and had symptoms completely relieved in about a month. The most severe of my patients were hospitalized, and the 2 most severe of them in 30 years of practice were each in the hospital for 77 consecutive days. One with abdominal pain and the other with vomiting. So in summary, there aren't any definitive tests for this condition, but if you know what to look for and you can uncover the underlying psychosocial issue that's responsible, or issues that's responsible for the condition, and there's almost always effective treatment for that condition, and when you see improvement, significant improvement, or even cure, then you know you're on the right track. But otherwise, these patients get frequently referred for consultant referrals and evaluations. There's an issue of false positive tests, where if you do enough diagnostic tests on people, you start to find things. And very often those things that you find are not connected to the illness, but they can lead to further tests or even surgery. Many patients who were sent to me, it was only after somebody had removed their gallbladder or their ovaries or their uterus or their spleen, or had back surgery, that didn't help them. And the end result of all this for many people is that serious illness is ruled out, but they remain ill, and they are wondering if they're going crazy because they know their symptoms are real, but nobody else seems to. Is there anything we can do about all this? Absolutely. You've already heard that we can diagnose and treat these patients just as successfully as we can anybody else if you know what to look for. But there are some barriers to our doing this effectively. The healthcare profession has known about this population of patients since the days of Hippocrates, but we haven't done much about it in the last 2,500 years, and part of it is down to the attitude of many healthcare clinicians. And what I mean by that is illustrated by this patient who was evaluated by a colleague of mine over a 9-month period of time, did every conceivable diagnostic test, and when there weren't any more tests to do, sent her to me for a second opinion. The only thing left to do was to ask her if she had any stress in her life, and sure enough, she did. And guess how long the stress had been going on? She'd been in a domestic violence situation for 9 months. So with the help of our social worker, we got her out of that situation into her own flat, and within weeks the pain was gone. So I informed this otherwise excellent physician about this very good outcome to her case, and he sent me back the following email. He really did. I didn't know whether to laugh or to cry. But yeah, this attitude is all too common amongst medical clinicians in particular, and that it's just, even though this kind of patient is 1/3 of our practice as gastroenterologists, which is what I am, he decided that this wasn't part of his job description. It's just appalling at how much suffering this woman had, not just from her illness, not just from the domestic violence, but from all those diagnostic tests, some of which were risky and many of which were expensive. Another barrier, and we all confront this, and it's the most common question I get from my medical audiences, is the patient's reluctance to accept stress as an explanation for their illness, because it just doesn't seem possible. Just how ill you can get. I mean, again, I had 2 patients in the hospital for 77 straight days. One of them was getting round-the-clock morphine. You can get any level of severity of symptoms from this. So we have to persuade people that stress causes real symptoms, that we are hearing them, we are compassionate toward them, we believe that their symptoms are real, and that if we can uncover the cause, effective treatment is available. So we need to get them on the same page. It's perfectly okay to pursue a purely biomedical approach with a patient on the one hand and do the psychophysiologic approach simultaneously on the other hand. That way patients are persuaded that we're not leaving no stones unturned in our efforts to find the answers for them. And typically that will persuade people that they'll play ball with us in terms of going down both roads at the same time. Once we're on the same page, we can do an approach that I refer to as a stress checkup, because it's a lot less stigmatizing than calling it a psychological assessment or a mental health evaluation. Everybody's got some stress, and we're just doing a stress checkup. And the first step is which may be very familiar to some of you and not so much to others, is to get a chronology of the course of the patient's symptoms. When and where did they start? Because not infrequently something bad happened right before the symptoms started. Not always, but not infrequently. So you want to know when and where they started and what's been their pattern over time. Because you may be able later on to match up when and where they had their symptoms with what was going on in their life at the time. You also want to look into anything that is suggesting that the illness is not physiologic. In other words, it is not related to an organ disorder or structural abnormality is what I should say. And what I mean by that is one patient whose chronology I got, his symptoms were only occurring while he was driving to work. See, now you've already diagnosed him. But just to confirm, he was not having any symptoms at all when he was driving home from work. And he was perfectly okay on the weekends when he was not at work. A slightly more difficult patient was one who had severe low back pain for over 25 years, man in his 70s. But nobody in all those 25 years had gotten the exact chronology, which was that he had his back pain 50 weeks out of the year. What was he doing the other 2 weeks? He was on holiday. What was he doing on holiday? Was he resting quietly on a warm beach, taking care of his back so that it wouldn't hurt? No, he was fly fishing in British Columbia. He's doing this, he's reaching into the bait bag, and when he's done fishing for the day, he's helping the lodge owner clear brush from behind the lodge. If anything, he's more active with his back when he's on holiday than he was at home when he was working, and yet on holiday, no back pain at all. This is, your vertebrae, your ligaments, your muscles, and your nerves do not know if you're on holiday or if you are at work. And just like the guy who was driving to work, I can tell you as a gastroenterologist that your large intestine doesn't know if you're driving to work or home from work. It's very dark in there. We have to bring our own lights. All right. Next part of the stress checkup. There's 6 parts. What stress are you under at the moment? What's going on in your life right now? Are you having a personal crisis? Is there a marital issue? Is there a workplace problem? Are there problems in your family? Almost anything that's bad that can happen to a human being. I've probably seen it create symptoms in somebody somewhere. Very important subset of this category is this one, insufficient personal time. These are people, you ask them, are you the kind of person that takes care of everybody else in your world but has difficulty putting yourself on the list of people you take care of? These are people that feel guilty if they get 5 or 10 minutes of free time and they're not doing something constructive. And how did these people get this way? Very often they grew up in stressful or dysfunctional home situations where they didn't get sufficient opportunities to play. Because when we play as young people, we are learning self-care skills. And if we don't get to play, we don't learn self-care skills. And as adults, when we get some free time, we don't know what to do with it, except do something constructive. So one example is a patient of mine who was managing the family checkbook for her 2 alcoholic parents from the age of 7 onwards. Another example, slightly different, was a patient who was a champion springboard diver, but she did her sport from the age of 4 onwards, before school, after school, and on weekends. It was kind of like her job for 14 years. And so now when I'm seeing her in the emergency room getting Dilaudid, which is a powerful morphine derivative, intravenously for belly pain, she had just hit the wall. She had no space in her life anywhere for herself. It was all about everybody else in her world. And then number 3, the biggest shock of my medical education was finding out that stress when you were a child could make you ill when you were an adult. And sometimes the illness starts when the person is still a child or an adolescent, or starts soon after they leave the family of origin, but not infrequently at all. The illness begins sometime in midlife. The very first patient, the one who triggered my interest in this field, was a woman who was perfectly healthy until age 35, and she suddenly started having one bowel movement a month, taking 4 different laxatives at double the usual doses, one bowel movement a month. So just out of the blue. It turned out that she'd been severely abused as a child, but nobody had laid a hand on her against her will for 25 years. And the illness just began in the, out of the blue, seemingly. And it took me quite a while to understand the process that could lead to something like that. And we're going to talk about that. But first, let's talk about the impact of childhood stress just on primary care. This was a study of 380 women, mean age 51, so they're decades removed from the abuse that they suffered, but 36% of them, an extraordinarily high number, abused as children, and the abused group had 37% more physical symptoms, even after all this time removed from the abuse, and double the rate of depression, just to throw that on top of everything else. Some of the best research on this has been mentioned earlier today, the ACE study. There's a great website, acesconnection.com, I think it is, or .org, where they talk about this. But in that study, they had multiple results, but the most chilling result was that in the top 16%, the most adversely affected group, compared to the group that had no adverse childhood experience, the group with the top 16% had a life expectancy 20 years shorter. So a huge impact on that population that lasted for a long time. Another study in this field that I like to report on was of pain in the female pelvis. They compared 2 groups that were undergoing laparoscopy, one group with the pain, the other group with no pain. The biggest difference between the 2 groups was in the rate of childhood sexual abuse. And you can see it here, 21%, which is unfortunately about average for adult women in the no pain group, but 3 times as high in the group with the pain. And again, these are adults. They are usually many years removed from the sexual abuse itself, and it's still having this impact badly enough that it's brought them to have a laparoscopy investigation. So what is the process by which a stress from long ago can lead to an illness in midlife? And ironically, it's actually part of a recovery process, and not every patient will go through a process like the one I'm going to describe. And some of them, the process is quite complex and is going to need very skilled and experienced psychotherapists to sort out. But in many of these patients, the process can be thought of with using an educational model. When I think about what distinguishes humanity from other species on the planet, one of the biggest differences is in our capacity to learn. But in these patients, what happens is they are learning things about themselves that aren't true. Their early environment is unhealthy or dysfunctional, and they're learning things. The biggest subject that we need to learn about as human beings is ourselves. But what if we're learning things about ourselves that simply aren't true? And one of the things that my patients have been taught by their environment, by events in their environment, is that they are not measuring up somehow. They are not worthy. Their boundaries of their body don't need to be respected. They are second-rate human beings, and they can get this message in any of a variety of ways. And the impact of that, of course, is to produce a profoundly low self-esteem that in these patients persists long into the adult years, and has a variety of other negative outcomes as well. One of the most important of which is that people who are brought up in an environment where they're taught that it's their job to fix whatever is wrong in the household, where they are second-rate human beings who don't deserve to receive back from their intimate relationships what they give to those relationships, it's not too big a surprise that they choose a bad partner for themselves, somebody who may be violent towards them or mistreat them. And they may choose one after another. One of my patients patients is a Hollywood actress who had a new boyfriend every 2 years for 20 years, and they were all rotten. The addictions is, the other items on this list are can often be best thought of as coping mechanisms for the emotional pain that these individuals are coping with. And I'll just mention that in the addictions, it's not only to substances. It's not unusual to see people who are addicted to things like work, sex, shopping. I've seen gambling, and probably a few others that I'm forgetting. Exercise is another one. The internet, yeah. One of my patients was addicted to stock trading and managed to take a, how do you make a small fortune in the stock market? You start with a large fortune. Yeah, tragically, that's exactly what he did. He started with $500,000 and not too long later, he was 200 in debt. All right, so there are, however, some positive outcomes, and anyone who's read any one of Dr. Sarno's books is very familiar with these. Being reliable, being detail-oriented, being perfectionist, being compassionate, being good to others, being hardworking. These are all qualities that are acquired in these dysfunctional environments where the child tries to be the best person that they possibly can be in order to reduce the level of stress and dysfunctionality and unhappiness in that home. These are all characteristics well described by Dr. Sarno in his work, and they all derive directly from people trying to cope with dysfunctional environments of one sort or another. And these are obviously beneficial. We wouldn't necessarily want anyone to acquire these skills in the way that they've been acquired in these patients, but they nevertheless have positive effects. The world loves people like this. They're exactly the kind of people you want to be your friend, your partner, your employee, your supervisor, your neighbor, your colleague. And so these individuals get a lot of positive feedback from the world in general. I've had many patients who told me that they're getting excellent evaluations in the workplace, while simultaneously they're getting very bad evaluations from their partner at home. So my typical question is, well, which do you think might be closer to the truth? And that gets people thinking. But the good side of this is that very low self-esteem with which so many of my patients emerge from their early years begins to improve in response to this. They're getting objective feedback from people outside the family, and that self-esteem very often subtly, slowly, unconsciously, subconsciously, unbeknownst to them, begins to march forwards, and when a critical mass of that change has had time to take place, they reach another stage in their recovery from the early dysfunctionality, and that's a stage I call I deserve better, where people, again, they may not have a real strong conscious awareness of this, but they start to feel like they deserve more respect, more support. My very first patient, the one who was moving her bowels once a month, she reached this stage, and we know that she reached this stage because she'd been working for the supervisor from hell for 10 years. And suddenly she decided, I've had enough, and she quit. And she worked in a bank. She had no trouble getting another job, very much like the original half a mile away, 2 miles away. Made her wonder why she hadn't quit sooner. Well, she hadn't quit sooner because she hadn't reached this stage. She had the bad partner in her life was her boss. So when they get to this point, you can tell because they're starting to make changes in their life that reflect this new attitude about themselves. The GPBI is the good partner, bad illness syndrome, because one of the things that happens to people when they reach this stage is that they are, for the first time, able to be in a relationship with somebody that supports them, where they get a 50-50 level of support from somebody else, somebody who really cares about them, a good partner. But all of these good things happening are ironically, often associated with the onset of illness. And why is that happening? Well, my conceptualization of this is that once you decide you deserve better in your life, you can't escape the corollary that you also deserved better when you were a kid. And what kinds of emotions begin to occur in response to that?
Feeling the anger.
Start feeling the anger, absolutely. Resentment, anger, you begin to recognize for the first time just how wronged you really were. And people get, really angry internally. Do they get angry externally? Well, some of them do, but they don't find their way to my office because they're giving headaches instead of getting them. But the ones who find their way to my office, they have spent so many of their formative years taking emotions and stuffing them in the back of their head somewhere that they don't have the skills for putting these emotions into words. So those emotions are sitting back there and they're building and they're building and they're building, and eventually they get expressed somatically somewhere in the body. It's an unpleasant emotion. And they may also have some hope for reconciliation with the people who mistreated them. But mostly, all those years spent surviving those challenging, difficult environments have made it almost impossible for them to move the emotions into the verbal part of their brain and start putting them into words. And so they just end up getting expressed somatically. Any questions about this process? We'll talk a little bit later about what we can do to help people. Okay, let's go ahead then and finish the last three parts of the stress checkup. And these are going to be more straightforward for many of you. They are mental health conditions that can present themselves primarily with a physical symptom. Depression is a very important one because it's well known through countless replicated studies that 2/3 of patients with depression, the diagnosis is missed in primary care. This is an unconscionable miss rate that would be unacceptable in any other form of illness, but it's routine for this diagnosis. The most likely single reason for this is that if you ask a lot of these patients, do you feel depressed, they'll say no. They'll say, well, they might admit to being exasperated or frustrated or stressed out. You may hear them say things like, I am all worn out, or they may express desperation about their symptom. You've got to help me with this. I'm at the end of my rope. I can't tolerate this condition anymore. Please do something. And when you ask them other questions about that link to depression, early morning awakening, loss of interest in things they used to love to do, crying for no obvious reason, thoughts of self-harm, then you're able to hone in on the fact that this is what they're suffering from. Post-traumatic stress, yesterday was the centenary of the Gallipoli invasion in 1915. Lots of post-traumatic stress there, known as shell shock in those days and attributed to moral weakness. We've come a long way since then, but rarely have my patients had any inquiry about this, so we've still got a ways to go. I can't say it's a common factor in people with psychophysiologic disorders, but it's definitely there. And sometimes it's very obvious if they had the trauma right before the onset of their symptoms, you've got a direct chronological link. There's another group of these patients where the trauma is remote in time from the onset of the symptoms. And in those cases, I look for a triggering event that is in some way linked to that trauma. And my favorite story about that is a patient with attacks of abdominal pain, nausea, and vomiting. They've been coming on intermittently for 3 years. And when I asked her where the pain was, she formed her hand into this shape and pointed at her right lower quadrant. And it turned out when we got to the trauma question that she had witnessed the shooting of her brother. And he'd been shot, no surprise, in the right lower quadrant. Bullet lacerated the iliac artery and he hemorrhaged to death in the ambulance. This had taken place over a decade before her illness began, so there was not an obvious chronological link. Asked her if she could remember a triggering event in any way connected with the trauma that might have occurred just before her illness. And sure enough, it turned out she had gone back to her family home in the central United States to attend her father's funeral. And while she was in town, she saw her brother's murderer in a convenience store. And he looked right at her. He didn't recognize her, but she recognized him. And it turned out the story was he'd been arrested. He'd served 8 or 9 years in prison for manslaughter because it was the shooting took place in a tavern brawl. And he'd been released back into the community, and nobody warned her that he was out there. So it came as a complete shock. And when she came back home to Oregon, where I live, she became symptomatic. One other quick story about post-traumatic stress, just to illustrate that it's not always these kind of horrible, violent sorts of traumas to look for. And this was a patient who baffled our cardiologist for 18 months with unexplained chest pains. And her trauma turned out to be she had a verbally and emotionally abusive mother who died. And after the funeral, she's in the family home going through personal effects and finds a letter in the family Bible that's written by her mother and addressed to her, and contains, among other things, a list of 10 reasons why I hate you. Nobody had asked her about trauma. And then finally, the anxiety disorders. Many of these patients are so anxious and have been anxious for so long that they don't recognize how anxious they are. So the clue that their illness is connected to an anxiety disorder is that their symptoms are much improved or even absent when they're in an environment they feel safe in. So for many people, a home environment they feel safe, and their symptoms may be much less there. My favorite story about this is a patient with attacks of diarrhea and abdominal cramps, very severe, came on out of the blue, had no rhyme or reason as to what was happening with them. But it turned out that she was having 2 or 3 of these a week. They've been going on for 9 months. So that's roughly 100 episodes, and not one of them took place at home. Statistically speaking, you know, since she's spending about half her time at home, she should have had 50 attacks at home. Not one. You know, once again, your large intestine doesn't know if you're at home or you're somewhere else. Only your brain knows that. All right, so barrier to good care number 3. Patients are often reluctant to accept referral to a mental health professional for a physical symptom. And this is a huge barrier. 80% of patients who are referred for a physical symptom to mental health either don't make or don't keep the appointment. So we need to find some ways to get around this. And one approach is this, that stress causes, we want to let patients know that stress causes real symptoms, that we want a specialist to help us uncover this or at least look into it. We want them to get a stress evaluation. And you need your mental health person that you're working with to be in on this terminology so that you both know about it, so that the patient says, but this is a psychologist you're sending me to see here. And you say, well, don't worry about that. Yes, the psychologist, they do take care of people who are seeing pink hippopotami in the parking lot, but we're not sending you over for that. We're sending you over for a stress evaluation, and that language might lower the barrier some. Another approach that I used in my practice was to start a class so that the kinds of ideas that you've heard from the speakers today and from myself, I would present them to a group. You know, it's almost as good presenting it to a group as it is one-on-one. And I promoted this heavily to the primary care department where I worked, and I was thinking they're going to love this. You know, I'm going to take on all the patients that they think might have some stress contributing to their illness. Well, it wasn't so easy. The first month, only 3 people showed up, and I was really depressed and was going to cancel the class. And my wife, who's sitting in the back, said, no, why don't you keep it going for a while? And what happened was the patients who came, they got something out of it. They shifted in their attribution of their symptoms to stress, to understanding that stress was connected in a much stronger way. They also had a reduction in the number of visits that they made with their doctors by 22%. And the doctors noticed this, and they started sending more patients. And what we ended up with was a 50% annual growth rate in the attendance to that class. And so it was very time efficient. We charged people, £5 or £10 to attend, so that made the information, I think, more valuable when you pay for it. But it was just to cover the cost of the room, really. And it just grew and grew, and the evaluations of it were very positive. All right, for patients who are the kinds of folks that take care of everybody else in their world and but don't quite know how to take care of themselves in the same way, they need to learn self-care skills. As I mentioned, they probably didn't learn them when they were children, so they need to learn them when they're an adult. And what I ask them to do, if they possibly can, and they may need the support of the people in their household, is take an afternoon, 4 or 5 hours a week, get out of the house and try to go do something self-indulgent. What we're looking for is activity that is the moral equivalent of finger paints for a 4-year-old. A 4-year-old doing finger paints doesn't care how many pictures per hour they produce. They don't care about the quality of the work. They don't care who sees it. They just know they're having fun. And these patients haven't had that in their lives before, and it may take them months to learn how to do this. Again, just through trial and error. And they're going to feel guilty doing this. They're going to think, oh, I should be back, cleaning the back bedroom or something. But I prepare them for that. So you're going to feel guilty, but this is a necessary human skill. We all need this. For myself, I played indoor soccer, every Thursday night for 22 years, and the team would go out for a beer afterwards. Sometimes we'd go out for a beer before. But that was, my personal stress reduction. After being kind and compassionate to my patients all week, it was great to go out and kick something. All right, so I'm gonna have to close very soon, but just in terms of a very simple set of concepts for how I treat childhood stress before I pass them on to a mental health professional, very often just these couple of simple concepts is enough to get people started on their own. Support their growth in self-esteem. Point out to them that a hero in our society is somebody who's overcome a difficult mental or physical challenge for a good cause. And my childhood stress survivors have done exactly that. And it sounds trite, but if they hear from a healthcare professional that they have done something heroic, it's a 180-degree flip in their self-image, or at least starts them moving in that direction, which for me, for my patients, is fundamental to additional changes that they're going to make later. We want to see if we can possibly bring unrecognized emotion into conscious awareness. And the one technique I'll pass along for that, and obviously you could do an entire training program in psychotherapy to learn how to do this, but one technique that's been helpful to me and to my patients is to ask people, well, would you be okay? A lot of people will minimize what they went through as kids until you ask them, well, would you be okay with this same experience happening to your own child? And then they're like, oh my God. It really hits home for them, and they oftentimes, for the first time, become connected with just exactly how tough it was. Or another way to put it is, what if I forced you somehow to recreate your childhood environment for your own child just for a week? What would it be like for you at the end of the week? My Hollywood actress patient said at the end of the week I would shoot myself. And for an hour before that, she'd been saying, yes, I went through this, but it wasn't that bad. I had this happen to me and it wasn't that bad. I dealt with it. Other people have had worse. And then she just completely stopped talking when I asked her about doing it to her own kid. And then finally, converting the somatic expression of emotion that we talked about earlier into verbal expression. And lots of ways of doing that: speaking into a recording device, writing into a journal. One that I like to suggest is writing a letter to your parent or parents who mistreated you. Not to mail it, just to write it. And people are not always ready right away, but once they are ready and once they start, it's very cathartic. I had one patient who made a deal with me. She was only going to write 2 paragraphs, and then I had to stop bugging her about it. But I said, okay, I don't think it's going to be enough. She wrote 2 paragraphs, and then she couldn't stop. 9 single-spaced pages by the time she was done. Another patient of mine, he took the letter to his father's grave and read it to him. It took him 4 or 5 hours. By the end, he was shouting. But that was the first time his symptoms improved. All right, the last thing. This patient, only 2 pieces of information were needed to cure her condition. Number 1, she was verbally and emotionally abused by her mother from the time she was 3 onwards. Still going on at age 50. Mother's in her 70s. You know, just you have to use your empathy skills to imagine what kind of emotional tension there was in that relationship. So that's piece of information number 1. Number 2 was that although most of her attacks of the nausea, vomiting, and dizziness happened in and around her home community, she would always get one of her attacks whenever she passed through a little town 45 minutes from where she lived. What was that about? Mom lives there. No, it wasn't that easy. The guys at Stanford probably would have figured it out. But it was almost that easy because Mom lived 2 hours further down the road. And the only time she ever went through this little town was when she was on her way to visit Mom. So all this emotional tension is building up and building up while she's on the road. Oh my God, we got this long weekend with Mom, and it's going to be living hell. Did she have the symptoms on her way home? No. She still wasn't convinced, and until I asked her one more question, which was, what happens if you drive 45 minutes in some other direction? Absolutely nothing. And that was her light bulb moment. I still remember her looking up at the ceiling and saying, oh my God, I can't believe it. 15 years of illness, 60 admissions to Stanford, a dozen specialists, and a psychiatrist. Hopefully you've got all of these websites, and there's some more I should have put on there. But I'll leave you with the final thought that if we had a blood test for this condition, you know, if we just, that would put it firmly in the, the biomedical realm that Adam talked about, and everybody in their healthcare professional training would spend as much time on this condition as we do on diabetes and heart disease and cancer. But when you think about it, the fact that we don't have a blood test for this condition, it means we really should be spending even more time because it's that much more difficult to diagnose. But everybody who works in this field has seen exponential growth in the interest and understanding over the last 5 years. So I'm confident that we're going to get there eventually. This is my contribution, which many of you have already seen. It consists mainly of 4 dozen case histories of different patients illustrating the spectrum of stresses that can make people physically ill. So I'll leave you with the website to make sure you got all of these. Thank you very much.